I was doing a cleft lip, even though I don't like them, and the electricity goes out.
Oh, wow.
Yeah, we don't have windows. We're in a little box of a room, and this is back in the days before you could just turn on your cell phone, right? And so we were all taught to carry our flashlights, and so everybody whips out their flashlight for me so I could see my little OR thing, look at my little patient and finish sewing. And no, the electricity never did come back on. And the anesthesiologist was able to work by hand. But, it's just things like that. You have to be incredibly flexible. You know they're going to happen. You're prepared for them. And instead of, panicking, you go, okay, this is what we prepped for. This was our, disaster management. And we're ready. We can handle this.
Hey, everybody. This is Caleb Steffen with Coast to Coast Plastic Surgery, and I'm very pleased to be with you today with one of my mentors, Dr. Debra Reilly, plastic surgeon renowned, and excited to talk to her about her plastic surgery practice and things that she's passionate about in plastic surgery. So welcome, everybody. Welcome, Dr. Reilly. Tell us
Thank
a little bit
you.
about yourself.
Fun to be here. Yeah. It's actually my first podcast, so we'll see.
Oh, cool. Yeah.
Yeah.
Well, we're all kind of new at this, right? So, well, tell us a little bit about your background, where you're from, family, those kinds of things.
Well, I am currently a plastic surgeon in Omaha, Nebraska. Had a little bit of a circuitous route getting here because I grew up partly in Texas and then was moved to Buffalo, New York for third grade. Left there for college, went back to Texas for medical school, did my all my medical school and my dare I say it, 9 years of surgical training in Texas.
The
And then I
people want
went
to
off.
know. They ought to know
You
how long
know,
it takes.
I'm dinosaur. They didn't even have a salary line for me my last year in residency because no one had ever taken 9 years to train before.
Right. PGY9, a made up thing.
Yeah, I had it. So I gave them a number and they didn't appreciate it. But anyway, so after that, I went out to California for 10 years. I spent some time in Sacramento at UC Davis, Northern California. Then I went down to University of Southern California, worked down there for a few
And
years. So
this was your time as an attending physician.
as an attending, yeah, my first job. Yeah.
So let's back up a little bit. For
Sure.
you, you mentioned 9 years of training. Even some of the medical people who might be listening or watching, that concept of what takes that long, or, because a family practice doctor, maybe 3 years of residency or internal medicine or some other things.
Yeah.
I dare say that plastic surgery is one of potentially, whether integrated or traditional, is still going to be one of the longest training programs there is. What was your experience like? What goes into that?
Well, back when I trained, there was no integrated. So your only option was to finish one of the surgical specialties for which you could become board certified. So I chose the general surgery route. And I was at UT Houston, which had a fabulous training ground for, I would say, people who didn't want to be general surgeons. We turned out a lot of cardiac surgeons, plastic surgeons, specialty colon surgeons, et cetera. But we had a research year. So besides the 5 years of general surgery, I added a research year, which I did at Brooke Army Burn Unit in San Antonio, which at the time, if you wanted to be anybody in the burn field, you had to go train with Colonel Pruitt. So I trained with Basil Pruitt, came back to finish general surgery, and I had the burn bug in medical school. So I knew I was going to be a burn doctor. I chose my residency programs all because of their burn expertise. So obviously I went back to Galveston, which is premier both adult and pediatric plastics. And that's a 3-year program. So 5 years general, 1 year of a burn fellowship. So I had my credentials, and then my 3 years of plastic surgery, which included, basically another year of burn care and reconstruction. So that was my
What's
9 years.
Yeah. Well, I spent a lot of time with you in my general surgery training at
You
Nebraska
did.
on the burn unit. And I actually in med school, I had a lot of had great burn experience at University of Kentucky, a burn
Mm-hmm.
unit there, University of Missouri, the burn unit there.
Yep.
It's interesting since my training, though, how much burn has moved away from plastic surgery and over to trauma critical care and general surgery. Have you noticed that, or since you
Oh,
were
yeah.
so involved with the burn unit at Nebraska while that was going, that may be not something that you got to experience firsthand so much, but I'm sure you heard about it.
Well, yeah, and everything that's old is new again, right? So plastic surgeons started the burn units. That's one of the reasons I was in Galveston. That unit had been started by the plastic surgeons. Then the general surgeons kinda took over for a while until they got something, more fun to do when laparoscopic came around, and they gave burns back to plastic surgery. And so as I was going through my early training and whatnot, many of the burn units were actually run by plastic surgeons. About 40 of the, say, 70 burn units actually had plastic surgeons as the head. Well, once the trauma surgeons got into doing less surgery and more ICU care, as their skills got better so they didn't have to operate all the time, they realized how much fun and lucrative burn care could be. And so they
Mhm.
kinda moved back into the ICU area and moved back into the burn field, and plastic surgeons migrated out to do fun things like microvascular and, some of the cosmetic things that are out there now. So, I've seen it do all full circles. When
Mhm.
I was going through, many of the presidents of the American Burn Association were plastic surgeons.
Okay.
Now, we had one 2 years ago from Canada, and other than that, it's been either ancillary general surgeons as the president. We don't have an incoming plastic surgeon right now, but,
Oh,
it'll
interesting.
circle around again.
Yeah. Well, I wanna a little bit later when we're talking more of surgery and less kind of plastic surgery background, I think it'd be fun to touch on burn care a little bit more in terms of
Mhm.
the actual procedure and the work itself. So going back to kind of where we left off, in terms of practice, what was your I really have no idea. I don't know anything about what your practice was like when you were in California, what you were up to, what those years were like as a young attending in that region.
So I went academic my whole way up until 2019. So I spent over 30 years in academic medicine. And I went to UC Davis because I knew they were going to open the brand new Shrine Burn Hospital and I
Mm,
wanted to be there when they started that. And the woman who was there as the head of the burn unit had been with me at Brooke Army. We had been residents together and we were one of the 3 teams at Brooke Army. We worked very well together. I knew her, she knew me, I knew she knew how to operate, she knew what I could do, and so we just formed a really cohesive team. We opened the Shrine, I worked there for a few years, and then got recruited down to USC, to do burn, but also to work at a, rehabilitation hospital called Rancho Los Amigos, where they did more than just burn reconstruction. We did a lot of pressure sore, post-trauma, that sort of thing, and I'd always had a background in wound care from Galveston and, of course, through
yes.
burn. And so being able to go down to Rancho Los Amigos and learn from a really phenomenal, kind of pressure sore chronic wound person, Dr. Rabai, was really quite fun. And there I worked at the big LA County burn unit, which was humongous load numbers of patients, again, pediatric and adult, because I've always done both adult and children, and just got a wealth of experience working with a whole new set of attendings.
Oh, that's neat. You
Mhm.
mentioned specifically that one of your early mentors was a woman at,
Yeah.
Sacramento, and I feel like, being a woman in surgery and plastic surgery has its own unique challenges even today, but the field was totally different in those days. I think there are more women
Yeah.
plastic surgeons now than there are men, or at least
Mhm.
in training. But those days were different. What was that like as a woman in those days, being kind of maybe should I say against the grain? What was or what was your experience like? Because I
Well,
know it's different. It was different.
yeah, medical school wasn't bad. We were 25% women in our
Okay.
class in Texas. So Texas was, I thought, fairly progressive at the time. We had an amazing woman general surgeon who ran the adult burn unit, Sally Apston, and she was a gruff old bird, but she had the golden heart for the residents and the medical students. So she had an office where if you had a bad day, you went in and turned the lights off and sat in her rocking chair, just calm and quiet until you pulled yourself together and went back out and did whatever you had to do. And if she found out you were having trouble, for whatever reason or from whatever faculty, she was there on your side to talk to you.
Mhm.
And then when I went through general surgery, not so much. Very few
Uh-huh.
residents, very few we think we had one pediatric cardiac surgeon who wasn't even there for very long. But when I went back to, Galveston, we had Linda Phillips, who as a junior faculty, who's now very senior and has been past president of the Plastic Surgery, Research Foundation, and so she was a mentor for me there. Now, Linda wasn't into burn care per se, but she was into reconstructive and being a really good plastic surgeon. And so for me, I was never the first woman to come through and do anything because
Mhm.
there's always that level, that age of women above me, but I was almost always the second.
Oh,
So
wow.
I was the 104th plastic surgeon to go through Galveston and only the second woman, things like that.
That's
Yeah.
that's
So
pretty special numbers there, paving the way.
even at Brooke Army, I had, the woman, Hannah Savage, that I worked with, who I ended up being a partner with. There were 2 other women there who were junior to me, one of whom is at Brown University as a breast reconstructive surgeon, and another woman who stayed in the Army, and she actually became, this was back in the '90s, and she was the chief, medical officer on the ship Hope. So she was a huge military doctor doing burn and trauma. So, I mean, we had a lot of us. We you bond together when there's not many. There
Uh-huh.
were when I started in '92 in plastics for my first job, there were 3 women, 3 burn units that had women running them or working at them. 3,
Mm.
okay? Now there's in our women's blog that, Tracy Short runs, I think there's 87, 90 of us on the blog that do burn care full or part-time. So the
So
field
re
has
so
expanded. Yeah,
so yeah, blazing some trails.
yeah.
Yes,
And you had to blaze sometimes. I mean, there are little fires here and there, but, that's the way I think all specialties, probably all forms of work go, not just surgery, not just plastic surgery, but any sort of, higher level workforce you wanna get into.
absolutely.
Yeah.
That's neat. Well, what was family life for you along the way, childhood, during that time and training and all of that?
Well, I grew up until I was 8 in Houston, Texas. And so what was going on in Houston in the '60s? We had NASA. So I
That's
was gonna
pretty
be a
neat.
first woman astronaut until I got
This
into
was your
glasses,
dream.
and at the time, you had to have perfect eyesight. So once I got into glasses, there goes, I can't be an astronaut now. And then we were inventing the breast implant. I mean, where did kind of cosmetic plastic surgery start was in Houston. So the 2 men that invented it, they're plastered all over the news in Houston, and they just seem to have the coolest lifestyle. And then we had Cooley and DeBakey defining cardiac surgery. Well,
Uh-huh.
all you ever heard about them was how hard they worked, right?
Right.
So, who wants to be a cardiac surgeon when you could go be a fun plastic surgeon? And so I had a very driven father who kept telling me, "Go do the cool plastic surgery life." And so I thought,
Mhm.
well, plastic surgery is fun, and I just had this idea in my head my whole life I was gonna go be a cool plastic surgeon. So that's what I kept looking at.
That's pretty neat, although oddly enough, with the hardworking, cardiac thing, and then, you wind up going to pick burn and complex reconstructive surgery. That
Yeah,
part of it, whether your father had that in mind or not,
no.
you didn't get to go put your feet up and play golf.
No, he actually thought it would have been a better idea if I'd been able to do that. Not that my family's never been incredibly anything other than proud, but it wasn't quite their idea. But when I got to Galveston as a medical student, we were asked to do some sort of social volunteerism, and I had been a music major in college. So I went to the Children's Shrine Hospital there. I went to the music room because that's where I was assigned and started playing with the kids. And I fell in love with the kids. And I
Mhm,
wanted to know why they were there, what was wrong with them.
mhm,
And this one little kid used to call me Sunshine when he'd see me, because I would take him outside. We had a little rooftop garden they could go out on,
mhm,
so they were still protected, whatever. And I would take him outside. And, once I fell in love with them, then I wanted to learn about them. And then my mentors in the burn field were plastic surgeons because they
mhm.
ran the shrine at that time. And so I was like, "Cool. I wanna do this." And then Sally Afston, who ran I mentioned her earlier, she ran the adult burn unit, wonderful mentor for medical students, and I just got the burn bug then, and it's never left me.
Mhm.
Yeah.
Yeah, it's interesting how the experiences during training,
Mhm.
childhood, all that influence who you'll be and what inspires you to do the next thing, isn't it?
It is. Yeah, even if you have an idea, like, how do I know when I'm headed into high school what plastic surgery means or what plastic surgery would evolve into? I
Yeah.
mean, now we have all kinds of amazing we didn't have all the microsurgery that we have now.
Right.
Right, we didn't have all the skin substitutes, all the ability to grow skin in a lab that we had. We didn't have the ability to do facial transplants. Things that we can do now that I never would have dreamed of, and yet I still fell in love with a career that I thought was evolving and I thought was important, and I got a lot of satisfaction from watching people heal up and get better.
Yeah. That's what it's all about. And I think sometimes with commercialized plastic surgery, sometimes that heart and that vision that you have and you've done through your whole career, I don't think sometimes that messaging really gets out there very much, does it?
And for me, and I know that's a little bit of an ego, but I can make someone who's not well when I see them. I have the ability to help guide them through a healing process to get to hopefully a good side. You're never better than you were when you started if you get burned. I thoroughly understand that, but at least get to a point where, you're functional, you return to family, society, back to work, back to whatever. And I really enjoy that progression being with the
Mhm.
patient. And there's other types of surgeries where you simply make people different. And is
Mhm.
different better? Yes, certainly sometimes in reconstruction, if we're taking a part that's been injured and we try to transform it into a part that's more functional,
Mhm.
we do make them different, and different is better. But I really like that ability to try to really improve someone from something, terrible that happened to them that's, a lot of times not their fault. How can you get them and their family through that? And that's
Mhm.
part of what attracted me to burn care is not just the little, 10 minutes I'm in the operating room or 3 or 4 hours in some cases, I know,
Right.
but it's that longer term care plan that I needed to do with the patients.
Mhm.
Mhm.
Absolutely. Well, it's that heart of the plastic surgeon, chapter 1, right? Restoration of form and function, isn't it?
Form and function, don't you know it?
Yep.
Yeah.
Do you have some most memorable moments or stories from medical school or residency that when you're thinking of those times that call to mind, either humorous or sad or happy, some moments like that?
Well, I always tell Sunshine Story, that
Yep.
that little boy was he was badly injured. He would come to the shrine every summer to get more reconstructive surgery, and I had a wonderful male mentor attending, and he would literally call me and say, "Sunshine's back in the hospital. Do you wanna come visit?"
Mm.
So things like that, I just remember, that's part the kindness of your mentor, but also
Mhm.
being able to follow somebody. I had one of the psychologists, Dr. Blakeney at, Galveston, and she taught me how to do hypnotherapy. And
Oh,
so I
cool.
could be called in to help in the tub room, in the procedure rooms, in the washing room for the patients to do hypnotherapy to kinda calm them down as an adjunct to all the pain medication that they were receiving. And so back in the, maybe the late '70s, early '80s, we didn't use quite as much pain medication as we do
Mhm.
sometimes now. We had to use adjunctive therapy with social distraction. Yeah, we didn't have VR headsets in the '80s, right? And so
Right?
hypnotherapy was a big thing. And I just
Yeah.
really appreciated the fact that my attendings recognized that I wanted to learn more, than what my little 1-month rotation was gonna teach me.
Well, if the podcast takes a little bit of an unusual turn at some point during that, you all will know what happened to me, right?
There you go. Right out to
Yeah.
sleep.
Very good.
Yeah.
Well, we've heard a lot about kind of your practice, some of the early years and things like that, and a little bit about some of your favorite surgeries. But I'd like to delve into I am guessing that most of the people listening really have a very poor understanding of what burn surgery is like. And, they've heard of things like skin grafts or things like that, but maybe take us through maybe someone who you might think has perhaps not every burn goes to the burn unit, right? Some just see their
Right.
family doctor, get a little medicine and do that. That's probably most of burns, but
Mhm.
that's not the people who needed your help. So take us through maybe the idea or one that comes to mind of kind of a burn patient and what is the process from when they get burned to when you get involved and how that what is the feel of that? What's the vibe of the burn patient and the treating plastic surgeon?
Well, for starters, just to remind people that really we used to think of, a burn like a big, huge burn. Like you see people in the movies excuse me, that, catch on fire. But really what we deal with the majority in the burn unit is a small burn, maybe part of an arm, part of a leg, maybe a little bit of a
Mhm.
shoulder, a chest. Maybe you spill something on yourself, you got a little bit of burn on your face. Well, the majority of those are going to heal up with what we call wound care. So that simply involves taking the wound, washing it with some sort of soap and water to remove anything that's draining, and applying an antibiotic ointment that's going to try to keep your chance of infection down. And sometimes it's actually an ointment, sometimes it's a gauze that'll contain a medicated ointment in it. And we'll put that on, which not only helps with infection, but kind of will cover and soothe the burn because we all know burns hurt.
Mhm.
Anytime you've injured the skin, you've got a nerve ending that's they out there exposed, that's firing off and gonna say, "This hurts." But if we can cover it and protect it while it's healing, we can decrease the pain that goes with it. So
Mhm.
part of what we're dealing with in burns is the fear and the anxiety of the pain that's gonna come during the wound healing process.
Mhm.
And this is gonna be true, like, anytime you break a bone, it's gonna hurt. If you get cut with a piece of glass, it's gonna hurt till it
Right.
starts to heal up. And as it heals, then you go through other sensations, like maybe pain from the swelling or muscle stiffness or itching. And burns will do that as they heal. Well, if the burn is deep enough through the skin, you can't actually, the body isn't able to heal it itself without creating a horrendous scar. And if
Mm.
it's a large enough area, you just can't heal it. So that's when the surgeon comes in and we have to replace the injured skin with skin donated from another part of the body. We shave a really thin piece of skin, thin like tissue paper, and we take that little thin piece of skin and put it on the area that's been burned after we've cleaned it really well and let that new skin graft onto it. And so that's why it's called a skin graft. You donate it from yourself to yourself, and then you have to heal up that site as well as the area we donated the skin from. Well,
Mhm.
one of the new things in burn in the last 10 years has been that we don't always have to use a lot of your own skin. So we have skin products now that come from cows, from fish, that are manufactured in a laboratory that mimic your skin, mimic the deeper layer of skin that has all the collagen and all the elastin that gives it some thickness and toughness. And if
Mhm.
we can put that down first and then put an ultra thin piece of your skin on top, we can minimize how much of your skin we need to replace the skin that was lost. And then we can even take your skin that we've harvested, that little thin area of skin, we can treat it chemically and turn it into a suspension in a little syringe, and then we can spray that skin on so that the small piece of skin that we took from you will cover a very large area of your burn so that we can get your burn covered without creating too much more in the way of scars where you've donated your skin from.
So for the scientifically minded in our audience, which would probably be a good part of them, a substitute is more or less what kind of mimics the dermis. Is that right?
Right.
The skin
And we call
substitutes
them,
that we use.
yeah, if they're not actual dermis, like dermis from a cow or a
Uh-huh.
fish or even a person, then we call them dermal, like regeneration templates.
Uh-huh.
They could be amnion. They like I said, fish and cow. We don't have frog skin in the U.S., but they do in South America. And so we take some of these artificial dermises, put them on, and let the new blood vessels ingrow, let the collagen, the elastin kind of remodel a little bit. And once the vascularity is good, then we can put the skin graft on. Now, the downside to that is it takes a while.
Right.
It can take
Takes
2 to
time.
4 weeks between surgeries.
Mhm.
And so you're trading off um, time for potentially better scar for healing. But if
Mhm.
we don't have the luxury of time, for instance, on my medical missions, I don't have a month that I'm gonna sit around and wait for something. You can
Right.
do the skin grafting directly and get a very similar result, we think, by just going straight from debriding, cleaning up your wound, your burn, and then skin grafting it to get it to heal.
For the people who are listening, I mentioned a couple other plastic surgeryisms, but replace like with like is one, isn't it?
Mhm.
So in terms of when someone's burned and the skin is gone, in one fashion or another, that's what we're trying to do, isn't it?
It is, and even if you think about your skin, different parts of your body are different colors.
Right.
So, Caleb, you don't have a lot of hair up there, and so you can tell kinda how pink your scalp is. Well,
That's
that
right.
scalp skin will match your face and your neck skin pretty good,
Right.
right? But if you had a burn up here and I took the skin from your thigh and skin grafted you up here, it turned out
Look
as a
like
pretty dark patch.
that's
Yeah,
right. I'd have some thigh skin on top of my head, wouldn't I?
you would, and it would be a different color. And so even when we're doing skin grafting, although, yes, we're trying to get you healed as fast as possible, keep you alive if you have a big burn, we still have to consider where we need to take that skin from so that your eventual scar is as good as it can be. So there's still a whole lot of thought process that goes into where do I get the skin from if I'm moving it. So if your burn is on your leg, I want the skin from your leg. If the burn's on your arm, I might want the skin from your chest right next to your arm, things like that, so that we can keep the color match as good as possible.
Hmm. I think that makes sense. You mentioned before about kind of hypnotherapy, and I think one
Yeah.
of the things that's most maybe mysterious to people and most concerning for people who've gone through burns is that experience in the tub room, or the minute they get into the trauma bay until it's time for that next part. What happens to those patients who have, say, we measure burns right at body surface area. So say that person who has a 30 or 40% burn, they're in real dire straits, aren't they? What is that like after they come in from the burn? The ambulances pick them up. Um, what happens next?
Well, I think that the first time you're going to clean anybody up, that is your best time to try to mitigate their pain and anxiety. And
Mm,
we know that there are medications we can give, like ketamine, that will alter, the perception of pain, et cetera, so that the patients don't learn the very first procedure that this is the worst thing that they're ever going to go through. And I
mhm,
think it's super, super important if they're coming through an emergency room or the first time you try to clean them up, that they are as sedated, as medicated, and as pharmacologically well treated as you can manage that.
mm,
Because then you can work with them with distraction, with fewer medications, but still with medications for pain and anxiety to help them through the next set of procedures. But we all know everybody's different. Some people can tolerate anything. "Doc, it doesn't hurt, keep going." And other people don't wanna see your face when you walk in the door. And so
right.
we have to be prepared to, if it takes a general anesthetic, to take somebody in and change a dressing, then that's what it takes. And if it only takes a little bit of medication to do that in your IV or oral, then that's what we're gonna substitute with.
But that
But
initial burn cleanup, trimming dead skin off, getting dirt and grime and gravel and grease and whatever else has happened, you find that's the time to set the stage for what the patient experience is gonna be.
But also that first dressing may just be the hardest one, because
Mhm.
once you get the dirt and gravel out of there, you're done, right? After
Right.
that, it's just keeping them clean. So we have a number of dressings now that we can use on patients that mean we don't have to do a dressing 1 or 2 times a day anymore. If I can get the wound clean, that first dressing change, when I've got the best chance of medicating the patient so that they're comfortable, and I can put on a dressing, maybe a silver impregnated dressing or one of our collagen dressings that contains, cell particles to it, or maybe one of my amnions, and I can put that dressing on with a cover over it. Sometimes I can leave that for 3 to 5 days,
Mhm.
and I'm not doing a painful daily dressing change. If I can get that burn wound cleaned up the first time, maybe the second time, and then I put a good stable dressing on, sometimes they'll even heal up underneath it, and that may be the only dressing they need in a burn wound that's not very deep. And then that will also tell you, if you wait a week, "Oh, this area healed, this area didn't. So now I know which area I need to operate on, and I've minimized the amount of eventual skin graft surgery I need to do." So I think that these skin substitutes have been incredibly useful for us in decreasing daily dressings, which decreases pain and anxiety, but also, improves our ability to determine depth of injury. Because we don't have any other way to tell except by looking at a wound over time exactly what needs surgery and what doesn't. We don't have good laser therapy. We don't have good ultraviolet therapy. We can't go biopsy every 2 centimeters to figure out how deep the injury is. And
The
so
burn
there's still
surgeons
some
ex
yeah, there's
No, go
room.
ahead.
excuse me, in
I was
burns,
going to
there's a
say,
lot of room for research in terms of trying to look at depth of injury and how to salvage areas of skin that are only partially injured, and you don't want them to convert from what we would call a superficial or second-degree burn to a full thickness or third-degree burn.
so really at this time, apart from the new research that may be done here in the future, it's really the burn surgeon's eyes, their experience, their knowledge that's really going to
Yeah.
guide the reconstructive process.
We still have to be at the bedside. You still have to be there. You can't look at a photo. You still have to touch it. You have to feel it. You have to look at the texture. You have to look at the turgor of the skin. So, it's still a bedside surgical process for us.
We've talked a lot about burn care and burn surgery. Would you say that that is your favorite surgery, kind of favorite care as a plastic surgeon, or do
Oh,
you have
yeah.
a particular procedure? Hands down.
Hands
Yeah.
down, I would rather do a burn than anything else in the world, and it could be an acute burn or a reconstructive case, but I'd rather be helping a burn patient. And not that I didn't love doing other things, but getting up and doing a burn in the morning, that was what shook my tree, that's what got me started.
Yeah.
That's what kept me going the whole time. Yeah.
And I'm guessing that what people don't necessarily understand about that, that we've delved into a little bit, is that burn care is kind of a continuum of getting through the clean it up process all the way through healing, right?
Right, 'cause it may depending on your age if you're a kid, it's gonna take you 2 to 3 years to finish that scar maturation, to take
Hmm.
that from a fresh scar to a mature scar that doesn't need any more work. And some of these scars that form tend to interfere with function. Maybe they're on a finger, you grab a curling iron, you get a burn here as a kid, but then it scars in and you can't straighten your finger out. So
Right.
we have to come along and help you straighten it by adding some skin or doing some work in here. Or maybe there's a scar on your face that needs to be maybe just removed.
Hmm.
There's a lot of things we can do to change scars, maybe remove them, maybe make them go away completely, or maybe do things that just gonna make them longer, stretch better, whatever, that we can do in the reconstructive phase after. And that can be done anytime. Sometimes we do it starting right away with lasers to try to soften a scar. And sometimes we can wait 10, 20 years till a scar becomes bothersome. And then you come in and say, "Can you fix this?" And we'll go, "Sure,
Yeah.
let's do it."
So it's not just the burn, it's also some side effects of the healing process
Right.
itself and scarring, like you mentioned. Yeah.
Yeah,
Yeah.
but then you get to meet the patient the whole time. So
Right.
kids I've taken care of when they were 4, I've been to their college graduations. One of my little girls just graduated from seminary a couple years ago,
Oh,
and
that's
she's now
cool.
a counselor for trauma-injured people. And she had a 40% burn as a child, which was pretty impressive and a lot of medical issues. Not medical, sorry, surgical issues. And I'm just so proud of her now for what she's accomplished and what she's doing. Yeah,
That's pretty neat. Very rewarding.
very.
So, on another rewarding part of your practice, I know a passion of yours is medical missions
Yes, it
and
is.
maybe surgical missions, or however you want to say it. So, tell us a little bit about how you even got started in that, and then we'd love to get into the details of what being a international mission plastic surgeon, what that's like, and those details. But how does one even get started on that? What was your journey for that?
Well, my journey for that is I love to travel, number 1. Number 2 is I thought when I was in high school, I thought about going into the Peace Corps before college. And then
Hmm.
my family was very into, "Can't you just go get educated and then figure out what you wanna do later? Let's not break up your high school, college the typical progression." So I said, "Okay," and went to college, but I always had that idea in my head, where could I go? What could I do? And when I got out of residency, I waited till I got board certified so that I knew I had all the credentials behind me that a good, well-trained plastic surgeon needed, and I went looking for a not-for-profit, an NGO group, that would take on a plastic surgeon who loved burn care. Because there's a lot of people that go out there, many, many plastic surgeons that do the cleft lip, the cleft palate, you
Hmm.
know, the pediatric things, totally needed around the world, but there were very few people going out and teaching burn care. And burn care is still a huge burden of trauma disease around the world. I mean, it's more important out there almost than almost any other traumatic problem that comes along because there's so few people that do it, excuse me, and so few reasons in the third world countries, especially how people get burned, open cook fires, terrible working conditions, etc. So I went with my first NGO group and had a great mentor for that. In fact, I'm still going on mission trips with him. I went to Bangladesh with him again last year. Fast forward, how many years was that? 30 years later, we're still operating together, which is just like amazing to me.
So it
And
didn't really come to you. You went out and got it.
Oh, I went out, look, I knew this is what I wanted to do and try to find, so I put my name out there. When I went to the meetings, the surgical plastic surgery meetings, I was like, "Hey, I wanna go on a mission." I'm not a good cleft surgeon. That's a three-dimensional ability that somehow bypassed me as a plastic surgeon, but I have the skill as a burn doctor, and I'm willing to do that, and I don't mind going on a mission out there and doing a burn while somebody else on the trip is doing, the cleft lip, palate, whatever. And
Right.
so I went out and put my soapbox out there, and people found me and took me along for that specific purpose.
Cool. What do you remember from that very first mission trip that you went on um, to Bangladesh? Was it that one was also to Bangladesh?
No,
Is that
that
right?
one wasn't that was just straight down to Mexico. We
Okay.
went down to a
What
little
was it
place
like?
in Mexico. At that time, I had a little bit of Spanish still that I remembered, and we went down to a ranch, that a wealthy woman rancher owned, and she had put together a mini little hospital for the people that worked on her ranch, and we were doing surgeries, and I needed an arm board. 'Cause I had a lady with a big tumor on her arm, and I needed to lay her arm out on aside the operating room table to take the tumor out. We didn't have an arm board. So, one of the nurses had brought her boyfriend with her, and he was a shop teacher in high school. So, he says, "What do you need? Give me dimensions." So, he goes out to the automotive store in this little town in Mexico, figures out how to get a clamp, gets me a metal plate. Then he goes to the automotive place where they, make the seats and whatnot, and he had him make a padded leather cover for me. And 4 hours later, comes back to the operating room and puts an arm board on the OR table for me so I could operate on this lady's arm.
That's neat.
That's neat. I mean, it was just like, really fun stuff like that, but I was doing a cleft lip even though I don't like them, and the electricity goes out.
Oh, wow.
Yeah, we don't have windows. We're in a little box of a room, and this is back in the days before you could just turn on your cell phone, right? And
Right.
so we were all taught to carry our flashlights. And so everybody whips out their flashlight for me so I could see my little OR thing, look at my little patient and finish sewing. And no, the electricity never did come back on. And the
Oh, wow.
anesthesiologist was able to work by hand. But, it's just things like that. You have to be incredibly flexible. You know they're going to happen. You're prepared for them, and instead of, panicking, you go, "Okay, this is what we prepped for. This was our, disaster management, and we're ready. We can handle this."
It's kind of we've talked about some plastic surgeryisms, but I'd say this is more on the trauma end, is right. Cool heads prevail, right? And you really,
Right.
as a plastic surgeon on a mission, you really have to have that
Oh,
cool
yeah.
head, don't you? Yeah.
Yeah, I mean,
Um,
losing electricity is probably about the worst thing that's happened, and that we're all prepared for. I've been lucky. I haven't been in any natural disasters, that
mhm.
have happened while I've been anywhere, which is good. I was under fire one time when the town we were in, Bolivia went under siege, and we had to be rescued in the back of an ambulance 3 days later, but we were
Oh, we got to hear more. We got to hear more about this.
yeah, we were barricaded in for a couple of days, my team, 5 of us. Obviously, no surgery was going on, and it was during a revolt in Bolivia. We were in a very small mountain town, and nobody in the US was hearing about this 'cause it involved only a little bit of the country. And a British CNN equivalent had broadcast some stuff about it, so our family had no idea what was going on. We were cut off, cell phone-wise, we couldn't get through, and finally, our host was able to get a Red Cross ambulance to cross over in the middle of the night through one of the barricades, put us in the back of the ambulance, and in the morning, they let us go through so we could get out of the barricaded area. But my nurses had been smart enough the day that all this started coming da we're given a lecture and we're hearing gunshots out the window, and we're like, "Oh, is that a car backfiring?" No. They were smart enough to go grab some food and water from one of the kiosks on the way to the hotel, which was the only thing we had to eat, plus our snacks for a couple of days, but no, there was no harm done, whatever, but it was just, didn't get to operate either.
Hmm.
Yeah.
That's pretty exciting.
It wa it It was more exciting in retrospect. It gave us an extra day in Bolivia, so we got to go to Lake Titicaca, and it was such a great name to say. It's always fun to say, "We've been to Lake Titicaca."
Right?
Yeah,
Yeah.
anyway.
That's one of the more interesting lake names, I think.
Yeah.
So where all have you been on medical missions where you like to travel? So, you mentioned what, Bolivia, Bangladesh, where all have your travels taken you?
Well, go back to India next week, which will be my 6th trip to India operating. I've been northern and southern India, so this is all kind of fun. I'll be in south central India now in Bangalore. But I've been to Armenia, right after, Russia left, so that was an interesting place to go way back when. I've been a couple trips to China. I've done 3 trips to Bangladesh. I've been down to Mexico many times. In South America, I've been down to Peru and, Argentina. I've been to Bolivia operating. I've been to some other countries like Chile for meetings, but not to operate there. So, a number of, fun places. I
Mhm.
used to say that I would only go if I could get a good R&R along with it.
Mm,
Now I've been to some of these places enough that I'll just go and come back, but it was always fun to have an extra day or 2. After you've met the people and learned a little bit about the culture, I
mhm,
think you got a whole different appreciation when you would go, excuse me, see a temple or go to an art museum or go to a musical event, something like the Chinese opera, which is so very different from my American opera. Um, you learn so much more about the culture when you're elbow to elbow with the people for a while.
mhm,
Mhm.
mhm. What are some of you mentioned the arm tumor, you mentioned some of the burns and things. What are some of the cleft lip? What are some of the memorable plastic surgery cases that you or patients even? Sometimes the patients are more memorable even than the surgery because at the end of the day, the surgery is neat for people, but at some point it's work, right? It's
Yeah.
work that we love. But what are some neat cases that you've seen over the years?
Well, I had, actually, it was that first trip again to Mexico. Obviously, it was memorable because it was imprinted on me because it was our first trip. But I had kind of a maybe a 30, 40-ish-year-old guy come, and he had a burn scar on his elbow that prevented him from straightening his arm out, okay? Because it was just a little band of scar tissue here,
Mhm.
something fairly simple for us to take care of. We can do some little, tricks to it and get it till it goes straight. Well, it turns out he was a clown. And he wanted to be able to do more of his clown work because he was limited in what he could do with some of his little magic tricks because his arm was bent up. And so he was so excited to come back to clinic and show us how his arm worked better so he could do some of his little magic tricks. I mean, it's just stuff like that is fun. One of my trips down to, Peru was again a cleft lip, cleft palate trip. And yes, I would help out on those if I ran out of burn cases to do. Excuse me. But this mother came in with her child, and the child had a cleft lip. So the split lip, we're gonna fix that. Mom had a split lip, never been fixed. Grandma, who came with them, had a split lip, never been fixed. So we fixed all 3 generations at one time.
Oh, that's so fun.
I know,
Why
and that's
why
just like,
is
oh.
obviously in America, when we're so preoccupied with, image and appearance and all that stuff, it makes a lot of sense. Why is it that internationally that clefts are so important that even goes beyond, that? Or what's your take on that?
Well, I mean, if you look at anybody, what do we call it? We call it a hair lip. We don't even have a nice name for it in
Right.
the lay literature, right? So it's not even a pleasant word. But for the babies, for the kids, they can have trouble feeding and swallowing if the muscles don't come together. If they can't form an oral competence, then their nutrition's going to be poor. And that's one of the problems we see in kids brought to us who are a couple of months old, who maybe haven't had the right kind of bottle feeding. Maybe they couldn't breastfeed because they couldn't latch on and suck on the nipple because they're missing the continuity of the muscles there. So part of getting it fixed is just to get their nutrition back so that they have some sort of function. Plus, it doesn't matter what society you're in, if you look really abnormal, there's going to be some form of ostracization that happens to you. So you may not be employable. Nobody wants to marry you. And if you can't get married, if you can't get a job, you're not gonna be much use in your society, and so it's gonna make it a lot harder for you to get along in life. The cleft palates, Again, that affects your speech, and if you can't communicate so that people can understand you, so fixing those palates in a timely fashion sometimes just to make speech improved so that you can communicate again for your social interactions in your job, is very important. And since cleft lips are congenital, they're gonna happen in X number of people per, number of babies born. Every year, every country is gonna have a number of clefts born no matter what you do to try to prevent this. Whereas with burn care, we are trying to do prevention in all
Right.
these third world countries. Get them not to use open flames. If we can get them to use some of the fancier stoves that have been invented, that you don't have to have an open flame. People still have. I'm wearing the wrong shirt today. I've got one with big white, sari type sleeves. No, you shouldn't be wearing that if you're going to cook. Is there something else you can do? Can we teach them child safety to keep the kids away from the fire pit? So burn prevention is helping and will continue to help, and education will continue to help, but not with cleft lip and palate. That's congenital. That's going to keep happening. Now we have to teach the surgeons in those countries, which is what we're doing. We have to teach those surgeons how to do the operation so that we are not going to be needed on quite the number of bases as we have in the past.
Right. Not just giving them a fish, but teaching them to fish, right?
Teaching them how to fish.
Yeah.
Exactly.
Yeah. And even some of these deformities, whether it's cleft lip or palate, in some of these countries, like the belief or the mindset is that they're cursed of God or have some sort of, or the
Oh,
gods are
yeah.
not looking
True.
favorably on them, or those things as well, right? And so you don't want to be near that person, and if that might rub off on you, and you'd fall in with their lot, right?
Right.
Because of the misfortune that they have. Yeah. Hmm.
Well, and we know that some of those are hereditary, so if you do have a cleft, it may make you less marriageable so that you don't produce a child with a cleft,
Hmm. Hmm.
right? Yeah, all those things.
Yeah. In terms of all those travels and those patients seen, you've also had an opportunity to work with a lot of different surgeons and trainees and things like that. What sorts of things, when you would talk to someone like myself or others who are interested in international mission, maybe haven't delved into the level that they would like, how do you take so many missions with a plastic surgery practice? How do you, as an academic surgeon, how do you get the chairman on board with you taking the time off you need to do it? How did you make the surgical missions work as a practicing surgeon? You have to have income. You have to do the things that the department wants you to do. You have maybe family obligations, things like that. And how did you make it work? What advice would you give to people who are interested in that sort of work?
Well, the one thing is, for the longest time, I didn't have a family, so I just needed a cat sitter, and so that was off the table for me, and I do believe that for some of my younger faculty that have kids, I tell them, "Just hang on and wait, until your kids are old enough and either your spouse can go with you or your spouse is okay taking care of the family with you while you go." So that is a problem. I don't really like going with residents because I worry that then I'm practicing on the patients rather than
Right.
I I I
Rather than curing, right?
I really believe that you should be board certified in your specialty to go down and work with people, so it is hard for me thought about taking a resident. I'm currently working with the American College of Surgeons on their Project Hope, and with their Project Hope, we have a combined teaching, agreement with the University of in Kigali, Rwanda. And so we're sending surgeons down, not only plastic surgeons, but vascular general, urology. We're going down there on a rotating basis. This will be my third year this fall. And we're going down as teaching professors. So one of the ways I think that you can talk to your chairman about it is, no, I'm going as part of the American College of Surgeons. I'm going on a teaching mission. I'm lecturing. I'm teaching residents. We have 11 plastic residents in Kigali from, I think, 4 different countries currently. They've started graduating residents. The first time I went to Kenya, there were 6 plastic surgeons in the whole country. They've now graduated over 30 plastic surgeons just in the last, 15 years. And so if we're going down and teaching and educating, I think that's how we do it. I think we can't just say, I'm going to go to Peru for, 10 days and operate and, come back home again. You have to show that you're giving back to the country and that
Mm,
you have residents coming with you to learn. They can't always get visas to come to the US or to go to India or to go to Australia or Britain to train. it's hard for them and expensive for them to get out of the country. So to train all these trainees they now have, they're bringing visiting professors in. I mean, my university in Kigali not only brings us in, but they're bringing people in from Ethiopia and people in from Sweden that come in and teach and train as well. So they get this incredible variety of visiting professors. So that's how they're learning. And I think that's one of the big ways that you can work with your chairman of the department. And then you can also produce papers. My Kigali residents have written 3 papers recently. On nutrition in the cleft lip and palate, nutrition in the burn patient, how to develop a burn registry. And so those sorts of activities improve your, academic productivity, and they also look good for your university. But you do have to have a sympathetic chair, I will admit that.
Yeah. You mentioned Project Hope specifically. I think people know of Operation Smile. Are there other organizations that you've enjoyed or appreciated their work, or things that you'd say, if you're trying to get started in surgical missions as a plastic surgeon, or maybe as another surgeon, right? It's not just plastic surgeons who are needed on these missions, but we do have a pretty wide set of skills that can be used there.
Right.
Um, are there other resources or places that you'd say, well, you ought to look into this or reach out to this
Yeah.
organization or that?
Well, there are hundreds of plastic surgery groups that go, and some places have their own little particular place they go all the time. I know University of Kansas goes down to Guatemala all the time. Austin Smile has a place that they go, and I'm not sure where, but I know that they go constantly. So somebody in your area may already be hooked up with a not-for-profit. Some of the bigger ones you've heard of, like Operation Smile, now has a burn section to it that Justin Gillenwater out of USC and my new partner, Eric Nagengast here in Omaha, both of them are working with that. I love going with Rotary International called Rotoplast, and that's basically funded by the American Rotary Clubs in association with the International Rotary Clubs, so that we're invited and we go with them and we go to a Rotary, person who's or group or club that's gonna help take care of us so that you feel very safe when you're going to these countries where you may not know, the way around. You don't even know where they are on a map until you get there. But as long as you know that you have a connection with a group in the US, it makes it much easier. I think the best way to do it is ask in your local, regional medical community, who's going, where have you been? And the same thing if you have a nurse that's interested to it. They can go to Rotoplast, they can go to OpSmile, they can sign online. You can fill out a form, tell them what you're interested in, what your skill set is, tell them how flexible you can be. Even if you're not a scrub nurse, but you can still circulate in an OR, or you remember enough about recovery room activity, you can help with that. And then there are, in many of these groups, we have room to take a layperson with us. So are you good at entertaining kids? Can you help them color and calm down, before surgery, whatever? Are you good at making arm boards, in the last minute for, whatever? Are you happy just schlepping around? We need 4 more new blankets for the patients coming up. Can you go to the little market and find me 4 blankets? So we always need people around us to kinda help, manage some of the last minute little things that we need. But really just asking, ask around in a meeting and ask around in your local group, and then just Google online what particular area of surgery you're interested in, and then see what comes up.
It's a team effort, isn't it?
It is, and I've been with a ton of different groups, but my favorite groups are the ones that teach, where we lecture, where we're associated with the university, where I've got a medical student or a resident coming with me from local, coming, to scrub with me side by side. Those are the missions that I really love to do the most. Yeah.
Neat. Any additional thoughts on surgical missions?
Boy, you just have to be flexible. I'm telling you. You be prepared for long waits. Be prepared to be able to do a surgery with minimal instruments. I once did a breast reconstruction in Haiti. I did a tram flap, back in the day, not a microvascular. I only used 7 instruments, and my scrub nurse was from University of Miami, and she said, at home, I would have had 3 trays for you. You did that whole surgery with 3 instruments." And I went, "Yep." I mean, we didn't have 3 trays, we only had 7 instruments. And so just that I think it really does utilize all the plastic surgery parts of your brain
Mhm.
when you go down there. and you have to figure out, "Hmm, I don't really have a needle holder. All I've got's a hemostat. Let's see what
Mhm.
I can do with this." Yeah. So,
Gotta make some, lemonade from whatever lemons are handed your way,
that's
right?
it, but that's what as plastic surgeons, that's why we're in the field because we can do that. We can flip a switch, we can be creative, we don't have to do anything the same way we've always done it. We can always find a workaround that is reasonable and useful and safe.
Creativity is allowed in plastic surgery, isn't it?
Yay! Obviously.
So, Dr. Riley, you mentioned to me before that I don't know if you have a date in mind necessarily for retirement, but it's on the radar maybe. Is that accurate?
Well, actually, Friday is my last clinic. So
No
2
kidding.
days
So
from
it is upon
2
us.
days from this recording is my last I've done my last operation in the United States, I think. And yes, I had a panic attack right before the case, realizing this may be the last time I'm in an American operating room. It was a very weird
Wow.
feeling, I know. And so I have my last follow-up clinic with that patient on Friday. So what can I say?
Well, looking back, this is an opportunity. I'm sure you've been doing some introspection, looking back on a wonderful and rewarding career. Um, what are your thoughts on that, or what do you have to say to the community, who is aware of plastic surgeries but maybe not understand it, or the resident or student who's thinking about plastic surgery? What are thoughts on looking at a very that everyone would perceive to be a very rewarding, very full career on that? Now you are at the end of it. We're watching it happen with you, so to speak, right now. What are your thoughts looking back?
Well, one of my thoughts is, where did the time go?
Mm,
I still have vivid memories from, as we talked about today, from medical school and residency that don't really seem like that long ago, and yet I know that I started medical school in 1979, and this
mm,
is 2025, so I know I've been at this a while. It doesn't feel like I've been at it long enough, so it almost feels like, "Why am I quitting now?" Do you wanna use the room retirement or quit? Because in a way, it almost feels like I'm quitting. I
mm.
still feel like I have a lot to give to the specialty and to the practice. I still got a brain, I've still got my hands, I've still got time. But then, at some point, you have to realize self-care comes into it, and you have to realize you are
Mhm.
getting older. I know that I couldn't probably be an ICU burn doctor easily anymore because I don't know if I could take be up all night, do the 2 or 3 days without coming home because I had a sick patient in the hospital. I can't do that anymore. And so for the last 5 years, I've transitioned into part-time with very little night call and in-hospital duties. Most of it was outpatient surgery. So that was a good segue, and I still have my mission work. I've already done 1 trip this year to Bangladesh. I'm headed to India next week. I'll be going back to Rwanda in October, and I may pick up something else in between. So I'm still gonna be actively teaching and working as a surgeon, which I think is also gonna help my brain realize that I'm aging out of the specialty. And so part of it is where did the time go?
Hmm.
Well, I had a variety of jobs. Even though they were all academic, they were all just a little bit different, different responsibilities, different progression in going from assistant, to associate to full professor and now professor emeritus. Um, you know, you have to live your life and time marches on. So, time to do other things, I hope.
Do you have advice for the young trainee or things of thinking about where the specialty is now, what you've seen it evolve from, things that you would recommend, things to consider or things to hope for or thoughts like that?
Well, and hopefully I said this to you at the time as well, but you never have to be bonded to your job, and especially your first job. That should just be the job where you learn to be a plastic all you've done is train up until now. You do not know how to be this was the advice I was given. I didn't believe it, but it's so true. You don't become a real surgeon until you've been out there on your own for a few years. I was told it took
Mm,
5 years. I felt it took 4, but, whatever. It takes a while to really wake up one day and realize that you are a surgeon, and as particularly you are a plastic surgeon. It doesn't happen just because somebody gives you a diploma one day at the end of
right.
June. Um, and so I think my biggest advice has always been, don't be afraid to change your job.
Mm,
If you have a job you started because you thought, it was safe, or it was a city I wanted to live in, or this was the income stream, the way that they were structuring my contract that I wanted, and then you work at it for a while and it doesn't work out, do not worry. This is what we do in you have to find your niche. Again, it's all part of being that malleable plastic surgeon. You have to find the niche of what you wanna do as a surgeon in a place you're comfortable. Because if you can't get up and go to work every day and be remotely, overwhelmed, happy, just, ecstatic, then you need to go find yourself someplace else to work, and it's okay to do that. Totally okay. Now, maybe you got lucky, Caleb, and could stay in one place, where you started. I don't think that happens very often in our field. And the other piece of advice is you've got to get boarded. You have got to get your board certification because that really is what says that, yes, I worked hard. Yes, I studied. I know what I'm doing. This is my proof to the world that I did what I was supposed to in my educational training.
So cherry on top, right?
Yeah. And there's
Yeah.
more cherries. You can become a fellow of the American College of Surgeons, which says that you're now an outstanding member in your own field. And then I became a fellow of the American Burn Association in the inaugural class because that said I was outstanding in my burn field. And each of those little cherries on top of cherries, just kind of highlight, at least for me in my own mind, that yes, I really did work this hard. Yes, I have accomplished this much. Yes, this is how busy I have been.
Silicone or saline implants and why?
Totally dependent on what the patient feels comfortable with. It was me, I would go for silicone. I think they have, especially in reconstruction, I think they have a little bit better texture and turgor to maintain a breast shape. But if I was older with a droopy, saggier breast, maybe I would go with a saline that I think is going to match the texture of an older breast better. But I think I still prefer silicone.
Sounds good. Pedicle and skin pattern for breast reduction and why?
Oh, I now am totally converted to superior medial because
Oh.
it is so fast. I've only had that pedicle die once, and it was in someone who was a smoker and didn't wanna tell me that,
Mm.
until her husband ratted her out, and she said, "Well, I just didn't believe you when you said that I should stop smoking." And I was like, "Oh, okay. Well, now do you believe me?" But, I do believe that even since it's a pseudo Weiss pattern, I do believe that it's a much faster operation for me, and I just think I make a cuter, B and C cup breast out of it.
Uh-huh. And skin pattern, wise pattern or vertical, or how are you doing your skin pattern
I'm
with the
still
superior
doing
medial
mostly
pedicle?
I'm doing mostly Weiss patterns. I get very few mastopexies. I get a lot of women with very large breasts where
Mhm.
I'm doing 1,200 to 2,000 per side and a vertical. And I don't know how to do a gigantomastia with a vertical.
I have done some that way before, and they do okay, but patients are generally happier at vertical excess, just letting it settle on its own. I think it does better
Yep,
just getting rid
yep,
of it.
definitely.
Yep, 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 yep. Okay. What is the best thing about being a plastic surgeon and why?
The best thing is creativity. I never have to do the same operation twice because no two patients are alike, and I don't have to follow a formula or a rule for anything. If I think I wanna tweak it this way or that, I have full, license to do whatever I want with the pedicle, with the flap, with the design, and that's where my creative mind always goes. I'm not, you know, I'm not except for arterial anatomy, I don't really have to follow a rule anytime I operate.
It's just principles, right?
Just
Just
principles,
plastic surgery
exactly.
principles. That's chapter 1 in the textbook, isn't it?
I never got past chapter 1, it sounds like.
That's funny. It means that the foundation is strong.
Yeah.
If I could do only one case as a plastic surgeon,
If I could only do one case, I'd excise and skin graft an acute burn. Yeah.
uh, what do you think about the new FDA labeling of breast implant associated illness?
So I that's a hard one for me. I did an awful lot of research in my residency before we had a name for it on what we thought was silicone-related disease. Um, and I do believe that even though we haven't found I can't do a blood test and tell you you have this illness, but I do believe there's a psychological component to it. And whether it's related to something we can't test and measure, or it's related to just the way people feel about their own body, There is a component of breast implant-associated illness that we need to take care of as surgeons, and if that means removing an implant, that means removing an implant. I have had anecdotally, you take that implant out and the patient's better the next day. Now, that cannot be all medical because you cannot clear anything out of your system that fast, usually. So we know there's a psychological component, but that's okay. If there's a component of it that we can take care of as surgeons, I think we need to. And we have to be willing to address the patient and the problem head on with reason.
Is there a role for textured implants in your practice, or do you think anyone's practice?
I'm just not gonna go there. I mean, I think we have enough evidence and some of the scary evidence with the, lymphomas and now with the squamous cell cancers that have been found. I'm petrified, basically, I mean, not totally, but I am so cognizant every time I go take an implant out, what do I need to biopsy if it's been a textured implant? And if a patient comes in and they've got their textured card, I really try to twist their arm to get that implant out, whereas normally I would just say, "This elective, it's up to you, whatever," if I know it's a smooth implant, but if it's textured, I'm really trying to get them to get that out so they don't become one of a very small number of statistics.
What are the highlights of your tummy tuck, whether it's weight loss or paniculectomy or things like that, that you would like to share?
Oh, man, my highlights, my largest paniculectomy, I removed 137 pounds.
That's a whole person.
That's a whole person.
And
Right,
for the layperson, that means the overhang of the tummy. Some people call it the Dunlop effect or this or that, but the overhang of the tummy onto the private area of the thighs that weighs people over. You'll see some people stooping and swaying because they have so much
right,
tummy hanging off. That's the pannus, right? That's what a paniculectomy is. 137 pounds. That's
137
got to be a
pounds.
state record, if not a
It's not necessarily one you wanna brag on, but I do think I have I might have a Guinness record in that one. But it was a
yeah,
patient we were able to help. He could only walk, less than 50 feet in a day, and we got him down from 700 to whatever, 550 pounds, got him into a program, got him on weight loss, then he got his bypass surgery, then he got another paniculectomy till he was down to 300 pounds and could walk 800 feet to 1,000 feet in a day. It takes a village to do that, but, I think some of these weight loss patients, they need a pre-paniculectomy to help get them to the point where they can get their weight loss, and after they've done their weight loss, it's tons of fun to take that extra nasty hanging pannus, that's lost all of the fat because they've lost, 80 to 100 pounds, and just throw that away. And so those tummy tucks I find fleur-de-lis if we're going on a pattern, 'cause, you
right.
have to get out the vertical, as well as the width. Just very rewarding to have those patients do so well afterwards. Yeah.
And just a touch for the person watching, fleur de lis means that we're getting rid of an up and down incision to get rid of the extra skin on the kind of the waist, this
Mhm.
dimension, and then a lower incision to get rid of the extra skin in this dimension. They truly can't, you can't really, you can kind of replace one sort of, but if you're really going after it, you really have to have both to make it happen. Correct?
Correct. Yep.
Correct.
Yep.
Um, who are your plastic surgery mentors or go-to texts for that matter?
Well, my first plastic surgery mentor, was in Galveston, Donald Parks. He was actually Canadian trained, and when he moved from Galveston to Houston as faculty, I kind of followed him as a resident because I thought he was so amazing, and he still is. And then my I trained with Marty Robson, who's no longer with us, but, he was an incredible researcher and just a very domineering type of individual in terms of being gung ho for plastics and burns and burn reconstruction. Um, but there's so many people out there that influence you along the way. Those were just my two biggest that were amazingly helpful.
That's cool. Uh, Trends that you're looking out for in the specialty in plastic surgery.
So the trends I'm looking for in plastics still have to do with skin coverage. And right now, we know that we have ways to kind of replace the dermis so that our scar may be better. We can spray skin on. We can't do pigment. I did
Mm,
tons of melanocyte research, had my own melanocyte laboratory along with the dermatologist when I was at UC Davis, trying to grow melanocytes in the lab, which we were able to do successfully. But the FDA has never allowed anybody to do a trial of deliberately spraying on melanocytes, my goal was to create a color wheel. I could say this many melanocytes would create this Fitzpatrick skin density type. And we never got that far in our lab, and no one else has yet either. We know that sometimes when you spray skin on, you occasionally get a melanocyte, but we need to do something consistently. So I'm really watching the trends in spray skin and being able to disaggregate the skin, isolate the skin types. Maybe when we're doing 3D reconstruction with printed 3D printed skin, when you're gonna put your wound or your ulcer underneath the 3D printed machine, and you can add in a drug, or you can add in a skin cell, or you could add in a melanocyte for color, we might be able to 3D print color. Think of it for people with vitiligo or people who just get a scar that heals. Like, if I put that patch of skin on your head that's the wrong color and you wanna recreate your natural skin color. Three-dimensional printing of skin with melanocyte isolation is something I'm super interested in. And one of the residents that I went to Bangladesh with, she's got patents in this already. And so she's actually working, it was her PhD when she was in training, and she's working on this 3D printing of skin. And I'm encouraging her to try to work with the lab in Australia where she's doing her current fellowship to 3D print melanocytes as well.
Yeah. For the people who aren't surgeons or medical, the printing of melanocytes give the color to our skin. So when you have someone who's burned, who is of African descent or other places besides Northern Europe, they're going to have higher levels of pigment, and those burn scars, are going to appear uniformly pink or pale compared to the rest of their skin, being a telltale sign of their burn. So if you're actually able to restore that color, it would be a much more magnificent reconstruction than just creating a germ
Exactly.
and moisture
Mhm.
barrier. If I said that correctly, I hope.
You did. Perfect.
Very good. Something that prospective patients should avoid, some sort of trend or thing that you've heard about on the web or on the news that is big guns now that really the public should be more wary of than necessarily they are. There's a lot of pretender people out there, right? Cosmetic surgeons, so called, who aren't plastic surgeons and things like that.
Um, the thing that I would ask people to be prepared for is be prepared to prehabilitate yourself before surgery.
Mhm.
And that means that you've got yourself, you're not smoking, you've got great nutrition on board, you've hydrated enough for water, you're doing your exercise. So if you look at some of these folks out there who are trying to get you to try the latest new diet or the latest fad or the latest baking soda, apple cider, or something or other. Those things may not be good enough for your body in terms of healing you from your surgeries. So, the trends and fads that I would ask you to stay away from are anything that you've got on your cell phone, off the YouTube or the internet. And that you go to a surgeon who is A, board certified, and B, is concerned about your healing and your potential for complications, because we all know they're gonna happen to somebody sometime, but that you try to prehabilitate yourself into the best shape you can to the best outcome for your surgery.
That's great. Dr. Riley, thank you so much. Professor Riley, thank you so much for joining us today. Just really encouraged by hearing about your career, the way you've been able to give back to your residents, your community, and the world, your gift of plastic surgery.
Thank
So
you.
thank you for doing that. Thank you for joining us on the program. And I will leave the floor to you for the final word.
Well, the final word is thank you for doing this because, like you say, a lot of people don't really understand what we do as plastic surgeons. And I want the world to know that we're more than just, your basic cosmetic surgeon out there, that there are people who really need us to do some reconstructive work. My joke always was if it looks bad and smells worse, I'm the plastic surgeon you want to call. So you never want to brag about having me as your plastic surgeon because that means you've been sick. Um, but I would also say to any of the younger people out there, the plastic surgeons out there, don't also be afraid to have another outlet of your creativity other than just your surgery. We can get so overwhelmed with our practice and the demands on our time, which can, just really make you not as pleasant a person once you get home as you could be. And so if you can take the time to do a mission work, if you can't do that early on, maybe you can do something else to give back in your community. There are plenty of clinics or medical students who need mentoring that are available for surgeons out there, even if you're not in academic plastic surgery, certainly. And just go to a meeting and network with your other peers. I think actually still physically going to a meeting once in a while, not just learning by Zoom, because we really are a social specialty. And I do think we learn a lot by talking to each other and interacting with each other. And it may not just be about what suture to use, but it may be about what suture to use. And if that helps you make a little procedure better, then so be it. But plastic surgery is fun, very fun. I am going to miss it a lot. I'm trying to learn to sew right now, and I'm much better on skin than I am with the sewing machine.
Mm.
But I've mastered one skill, I should be able to master another.
Well, thank you, Dr. Reilly, for joining us, and thank you all who are either listening or watching. God bless, and we'll see you next time.